next up, we have Dr. Dagogo-Jack. Moving further north, I guess. We've gone from North Carolina to Philadelphia, and now all the way up to Boston for a talk on the future uses of liquid biopsies. Dr. Dagogo-Jack.
Perfect. Thank you, Dr. Weiss. And good morning to everyone wherever you are. And it's a pleasure to have you here. I want to give a warning that my slides will actually be advanced on my behalf. So I apologize. I'm going to say next slide a lot during this talk. And so the focus of this talk is really discussing future applications of liquid biopsies. And I want to give the disclaimer up front that a lot of what I'm discussing is based on small studies and will have to be validated with upcoming larger studies. So with that, we can advance to the next slide. And these are my disclosures. So next slide. And so there's two, in this brief talk, I hope to discuss two main areas. One, I'm going to discuss emerging types of liquid biopsies. You've heard from Dr. Thompson that in clinical practice, when we mention liquid biopsies, it most commonly refers to circulating tumor DNA. But I think that we're just scratching the surface, and there are many other liquid biopsies that we can think about. And the bulk of the talk will really focus on discussing where the field of liquid biopsy is moving and looking at three particular areas. So can we use liquid biopsies to predict outcomes or prognosticate? Can we use it to detect patients who have residual disease after they receive surgery or radiation to tell us or kind of inform us to distinguish between patients who are already cured versus those who might be at higher risk for relapse? And then the third application that is very exciting is whether or not we can add liquid biopsies to our existing screening strategies to enhance the yield of early detection of lung cancer. And so with that, we'll advance to the next slide. And so when we, as Dr. Thompson discussed, so in most conversations, if you hear liquid biopsies in the context of lung cancer, we are referring to circulating tumor DNA analysis, or also called cell-free DNA analysis. And what this refers to is that the shedding or kind of the release of genetic material or DNA from tumor cells that are dying into the bloodstream. But that is not the only source of DNA or tumor-derived genetic material in the circulation or in the bloodstream. There's multiple studies that have shown that this DNA, in addition to being kind of free-floating, like in circulating tumor DNA, can be contained in the intact tumor cells themselves that have broken away from the bulk mass or the bulk tumor, either as individual cells or clusters of cells. And it can actually also be encompassed or encapsulated in more complex things called exosomes or microvesicles. These, for a lack of a better way to describe it, are little kind of lipid pockets that contain little pieces of information from the tumor. And the reason that a lot of our focus in this talk and in the prior talk is on circulating tumor DNA analysis is that it's a little bit harder to identify and isolate these circulating tumor cells and exosomes and microvesicles with our current technologies. But I have confidence that in the next few years, we'll be able to overcome some of these barriers and we'll be able to better leverage some of these additional plasma biomarkers and plasma liquid biopsies. Next slide. And so Dr. Thompson had one slide that he put up that mentioned that liquid biopsies aren't just contained to the blood, that you can get liquids from other biofluids. And the reason that matters, I think, in thinking about future liquid biopsies is that we've learned that the tumor and disease characteristics really impact the ctDNA yield. And what I mean by that is that because the majority of cells in your bloodstream are actually non-tumor derived, meaning they're normal cells, the majority of DNA in your bloodstream is actually not related to cancer. So sometimes trying to pick out tumor-specific DNA can be like looking for a needle in a haystack. There are certain features or factors that make the amount of tumor DNA higher, and it kind of boils down to having more tumor burden. So we see across studies, this is just one representative study, that as you increase the stage of the tumor, you're more likely to detect circulating tumor DNA in patients. And so this is a small study using a very, very sensitive assay where you increase from 42% of patients having detectable ctDNA to over 80 in stage 3. I would say that with most of our assays that you're able to order off the shelf, the numbers are probably slightly lower with stage 3. And then when we even think of patients who have stage 4 lung cancer, there's still variability in the amount of ctDNA we're able to recover with a basic ctDNA assay. And that's because the amount of cancer that you have in your body dictates the amount of ctDNA in the circulation. We've learned through multiple studies led at Penn and other sites that the number of metastatic sites matters. The more metastatic sites you have, the higher the burden of circulating tumor DNA, and the more reliable our tests are. And that is, more ctDNA, the greater ability you have to actually detect relevant mutations in the plasma. That's a term that you'll see come up. That's a term called sensitivity, the ability to find something that's actually present, and we know that it's present based on tissue in these studies. We also know, though, that there are some disease sites that actually shed less ctDNA. So you can have a lot of tumor in the lungs or in the brain, but those tumor cells, or the DNA from those tumor cells, may not find its way into the bloodstream. And so future directions of liquid biopsies would be kind of looking towards alternative sources of liquids for figuring out what is going on with the tumor at some of these disease sites. So with that, we'll go to the next slide. And so one potential strategy that's being explored, again, still investigational, but very exciting from my standpoint, is whether or not for patients who have most of their cancer in the lungs and whose cancer is growing in the lungs, where a liquid biopsy or a plasma biopsy may be less informative, whether we can go closer to the lungs and actually sample fluid in basically the breath, look for DNA and proteins in the breath that are related to cancer. And so this is just one representative study, but there have been a handful of studies that have shown a similar concept. And so what this study is asking, so Dr. Weiss talked to you about EGFR mutations. So this is a population of patients, a small group of about 10 patients who have lung cancer with an EGFR mutation. It is known based on tissue, and they're trying to check whether or not you can detect the same mutation in plasma, the blood, or in the breath for patients that I've highlighted in red there, who are progressing only in the lung. So the cancer is only growing in the lung. And what you see, and what is encouraging to me, is that for the patients who the plasma was negative or unrevealing, the breath sample was able to detect this mutation. So while it's still early days for this technology, it does suggest that we should start looking at other bodily fluids too, and we can still do this in a non-invasive fashion. Now turning towards the next slide. And so for the rest of this talk, we're really going to focus on where I think the field of liquid biopsy is moving and focus on these three areas highlighted here. And so going to the next slide. And so you've heard from Dr. Thompson that one of the advantages, perhaps one of the greatest advantages of a liquid biopsy versus a tissue biopsy, is that liquid biopsies are non-invasive. This allows for what we call longitudinal assessment or serial sampling to figure out kind of in real time how the tumor's makeup is changing over time in the face of therapies. And so this ability to repeatedly sample plasma or circulating tumor DNA has invited the question of whether we can use the dynamics, so whether or not the amount of circulating tumor DNA is increasing or decreasing, to get some clues about how well someone is going to do on therapy. And so this has initially been investigated in the setting of patients with metastatic lung cancer who are receiving targeted therapies. In these studies, patients receiving EGFR targeted therapies, ALK targeted therapies, MET targeted therapies, basically you name it, blood was collected prior to starting treatment and then early on treatment, so about 1 to 2 months on treatment. And they compared the amount of circulating tumor DNA at each of these time points. And all of these studies have noted that those patients where the circulating tumor DNA decreases are more likely to benefit from therapy, so to remain on therapy longer, than those where the circulating tumor DNA stays the same or increases. So that's exemplified here in a study for patients who received a recently approved drug called tepotinib because their cancer has a MET mutation in it. Here we see that when you compare the group of patients with a molecular response, that is decrease in the circulating tumor DNA, to those who are termed molecular progressors, because the circulating tumor DNA is increasing, that there's dramatic differences in the response rate. So 90% in one group versus 0% in one group, and dramatic differences in the amount of time that someone can stay on therapy before the cancer progresses, to the tune of 5 months versus 20 months. And if we advance, we can see that similar concepts hold for the kind of the polar opposite or the opposite end, stage 1 lung cancer. And so for those of you who are not familiar with the management of stage 1 lung cancer, it's in fact the opposite of stage 4, where the backbone of therapy is systemic therapy, like chemo, targeted therapy, immune therapies. For stage 1 lung cancer, the mainstay or backbone of therapy is really surgery, and the minority of patients actually receive systemic therapy. So what this study was asking is, if someone has higher levels of circulating tumor DNA prior to surgery, do they kind of behave equally to someone who has lower levels in terms of what is the chance that they're going to develop metastatic disease in their lifetime? And here they followed it out to 100 months, as you can see on the x-axis. And this study showed, again, using small numbers of patients, that if you have circulating tumor DNA, higher levels pre-treatment, you're more likely to develop metastatic disease. So what these small studies tell us is that quantifying the burden or the amount of circulating tumor DNA can give us some insights about prognosis. So how do we apply that to the clinic? Next slide. And so one potential strategy, again, this is investigational, but currently being explored in clinical trials, is what if you took patients who were diagnosed with stage 4 lung cancer, you already did the NGS testing that we heard is very important from Dr. Weiss and Dr. Thompson, and you identify an actionable mutation or fusion rearrangement, and you're starting someone on targeted therapy. And you check the plasma biopsy or liquid biopsy at baseline, and then again at 1 to 2 months on treatment, and you compare the amount of circulating tumor DNA in each. And for patients where the circulating tumor DNA was decreasing or had completely disappeared from the blood tube or in your assay, you couldn't detect it, you feel reassured, and so you continue the targeted therapy. But for those patients where the actual amount of circulating tumor DNA hasn't budged or it's increasing, one might think about continuing the targeted therapy, but adding something else. And so this is investigational, but this is being explored in an ongoing study called the Shetter study that's being led by Helena Yu at Memorial. Next slide. And so that's the context for stage 4. What about kind of stage 1 to 3 lung cancer? And stage 1 to 3 lung cancer is distinguished in that although these are all kind of a variety of stages, the intent is always the same. We're intending as physicians to cure our patients, but unfortunately there's significant heterogeneity in terms of outcomes. Some patients do better, and how well you do is really proportional to stage. So when we look at 5-year survival, it can be 90% or higher for stage 1 and as low as 30 to 40% despite surgery for stage 3. Our historical standard has been to try to improve those odds by giving chemotherapy for 12 weeks afterwards. But that only yields modest survival gains to the tune of 5% improvement in survival at 5 years. So can we use circulating tumor DNA to do better, to help identify those patients who are cured versus those who are not cured? So can we advance to the next slide? And so this was explored kind of again in a smaller study by a group in Stanford, where they took patients who were being treated with curative intent. So they'd finished surgery or they'd finished radiation. And then they basically took a tube of blood and looked and saw, is there circulating tumor DNA present or is there no circulating tumor DNA present? And then they assessed whether or not that impacted whether or not someone's cancer would progress over time. So the black line is patients who never had circulating tumor DNA detected. And what you can see is that at 3 years, none of those patients progressed or passed away from their cancer. And that's in contrast to patients who had ever had circulating tumor DNA detected. So in our current practice, the way that we try to assess whether or not someone's cancer has come back after we've treated them for curative intent is to get a scan and to get multiple scans and to follow them over time. So if we advance to the next image, it is humbling kind of in light of that with the tools that we use in clinic to kind of recognize and realize that those are blunt instruments compared to circulating tumor DNA based on these small studies. And so in this study, they took patients and compared scan findings to circulating tumor DNA findings and assessed whether or not patients relapse. And so if we look at the bar at the top, the green is patients who had no evidence of disease in scans. Yellow is scans where they didn't give a clear yes or no versus in terms of whether or not someone's cancer had come back. And so these are situations where you would continue to watch someone probably and you wouldn't start a therapy. But of those patients who belong to those categories, if they had circulating tumor DNA detected, all of them relapsed. All of them had their cancer come back. So this suggests that ctDNA may be more informative than scans for predicting relapse. And so how do we get that or translate that into the clinic? So if we advance the next slide. one can imagine a study similar to this, but probably would need some refinement, where you would start with surgery, you would get a tube of blood, and you would check to see a liquid biopsy and check to see if there's circulating tumor DNA present or absent. If it's absent and someone is not leaning towards chemo, you can feel reassured in that decision. But if it's positive, then you proceed to chemo. And because as mentioned, chemo only yields a modest benefit, you check again after chemo. And based on whether or not it's positive or negative, you can assign people to receive additional therapy. So I think this is the direction that future studies are moving in. So if we advance to the next slide, one area that I really wanted to emphasize is that, the ultimate goal of all of your oncologists, your thoracic oncologists, is that we want all of our patients to have stage 1 lung cancer, right? We want all our patients to be cured. And currently, the best way to do that is early detection. In current practice, the only strategy for early detection that's actually approved is doing a low-dose CT screen. But the uptake for that is very, very low. So these are data presented at ASCO this year that shows that among all eligible patients who are eligible for receiving CT screening based on smoking history and whether or not they're currently smoking or not, less than a fifth of such patients actually get a low-dose CT scan. And even if you look among patients who have an order for the scan to see how many of them actually even get the scan, a third of patients don't actually get that first scan. This is one limitation of CT screening. The other is that the criteria don't apply to everyone. And so if we advance to the next slide, there are limitations that are evident for our current CT screening practices. And one of them is really that while the sensitivity is high, meaning we can detect the cancer if it's present, it has a low specificity. So sometimes we find things that aren't cancer, and that leads to a lot of anxiety. And so one direction that the field is heading is, can we add things to CT scans to improve the yield or the specificity, the ability to tell if there's cancer there or not? And so there's been a variety of plasma tests that have been developed to answer this question. And I think it's reassuring to find that, particularly in the context of stage 1 lung cancer, that the specificity of these tests is higher than 90%. It can find a cancer if it's there, but it has the opposite problem in that it has lower sensitivity, especially for stage 1. And that really goes back to the concept that the majority of cells in the bloodstream are not related to cancer. So if you're really trying to find the earliest stage of cancer, you have to do more. And right now, based on how the tests are designed, they're probably best suited to be paired with CT, screening CT. And so final slide. Advance to the next slide, sorry. Well, so in summary, I just wanted to highlight that we are only scratching the surface of liquid biopsies by doing circulating tumor DNA analysis, and there's multiple other sources of liquid biopsy that I look forward to seeing in the future. We have learned from the studies that I presented that tracking tumor DNA can tell us some prognostic information. We also know that we can use very specialized tests to perhaps distinguish patients who are going to have their cancer come back versus those who are cured, and hopefully we can use these types of assays to inform future practice. And we've already seen encouraging things from early studies for using plasma to inform early detection, but we still have our work cut out. Thank you for your time.